Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 463 of our pharmacotherapy series, which majors in adult hematologic malignancies. The first case reads, JVC, a 57-year-old man, presented to the emergency department with increasing fatigue and fever and an inability to eat. This past week, a peripheral blood smear, complete blood count, abbreviated as CBC, revealed a white blood cell, abbreviated as WBC, count of 180,000 cells per microliter, with a differential of more than 90% leukemic blasts. The normal value should be 0%, a hemoglobin of 7.8 grams per deciliter, and a platelet count of 46,000 cells per microliter. A bone marrow aspirate and biopsy confirmed the diagnosis of acute myeloid leukemia, FAB-M2, myeloid with maturation, 60% blasts, myeloperoxidase positive, CD13 and CD33 positive. All serum chemistry values were within normal limits, with the exception of potassium, which is 3.2 milliequivalents per liter, phosphorus, 5.5 milligrams per deciliter, and lactate dehydrogenase, LDH, of 3,500 units per milliliter. Physical examination was remarkable for oral leukoplakia from oral candidiasis and poor dentition. So my first question to you reads, which signs and symptoms exhibited by JVC are consistent with acute myeloid leukemia? JVC's symptoms of increasing fatigue and fever of 1 week's duration are consistent with a rapid reduction in red blood cells leading to anemia, that is a hemoglobin of 7.8 grams per deciliter, and a low neutrophil count leading to infection, manifesting as oral candidiasis. Although his WBC count is high, the differential reveals that more than 90% are blasts, which are immature, non-functional cells of myeloid or lymphoid origin. Circulating blast cells are typically not present in early chronic leukemias or mild to moderate infections. However, blasts may be observed on the peripheral blood smear in patients with anemia associated with primary bone marrow dysfunction, that is myelodysplastic syndromes. Blasts are also present in patients with severe infection, stress, or trauma, and in those with chronic myelogenous leukemia, abbreviated as CML, in transformation to acute leukemia. JVC's platelet count is also low, which may lead to bleeding or bruising. Collectively, these are presenting signs and symptoms of acute leukemia. JVC's symptoms are consistent with either acute myeloid leukemia or acute lymphocytic leukemia, abbreviated as ALL. However, Patients with acute lymphocytic leukemia also commonly present with lymphadenopathy and hepatosplenomegaly, which JVC does not have. It is important to distinguish between these two disorders because treatment regimens differ greatly. Acute myeloid leukemia is more common in adults than in children. We will briefly discuss the classification and diagnosis. For a definitive diagnosis of acute myeloid leukemia, the bone marrow aspirate must contain more than 20% leukemic blast cells. A normal bone marrow aspirate would typically contain less than 5% blasts. 8 major variants of acute myeloid leukemia are defined by the French-American British, abbreviated as FAB, classification system based on morphologic characteristics. More recently, the World Health Organization has developed a classification system that expands the number of acute myeloid leukemia subtypes and better incorporates genotypic information, which is important in determining prognosis. Cells of myeloid origin commonly contain myeloperoxidase enzymes and express surface markers CD13, CD33, CD14, and CD15. Specific clonal chromosomal abnormalities are associated with several acute myeloid leukemia subtypes. These aberrations include gains or losses of whole chromosomes on the long, that is Q, or short, that is P, arms, as well as a variety of structural rearrangements, e.g., translocations, inversions, insertions. A number of cytogenetic abnormalities in acute myeloid leukemia are associated with molecular clinical syndromes, which are now under investigation at the genetic level. The translocation T15, 17, is the cytogenetic hallmark of acute promyelocytic leukemia, abbreviated as APL or AMLM3. This translocation splits the retinoic acid receptor gene on chromosome 17 and blocks expression of retinoic acid-controlled genes required for cell differentiation. Treating patients who have acute promyelocytic leukemia with all trans-retinoic acid, abbreviated as ATRA, tretinoin, has resulted in complete morphologic responses. This example shows how defining cytogenetic or chromosomal abnormalities in acute leukemia can be critical to understanding its pathophysiology and identifying optimal treatments. Currently, 3 chromosomal abnormalities are recognized as being associated with a better prognosis: T8, 21, T15, 17, and inversion, INV, 16. In contrast, several chromosomal abnormalities have been associated with a relatively poor prognosis, including INV3, deletion, del, 5, del, 5q, del, 7, and del, 7q, trisomy 8, and complex, 3 or more unrelated cytogenetic abnormalities, cytogenetics. Additionally, molecular abnormalities such as FLT3, which is generally unfavorable, and NPM1 and C, EBPA, which are generally favorable, are central in the evaluation of acute myeloid leukemia patients. These findings are increasingly being used to guide treatment decisions. For example, patients with cytogenetic and molecular findings associated with a poor prognosis may be considered for more aggressive post-remission therapy such as high-dose chemotherapy with hematopoietic cell transplantation. Other poor prognostic signs in acute myeloid leukemia include age older than 60 years at the time of diagnosis, a pre-existing hematologic disorder, e.g., myelodysplastic syndrome, prior exposure to a chemotherapy agent, e.g., a secondary leukemia, and poor baseline performance status. JVC has FAB-M2, myelomonocytic, acute myeloid leukemia. Approximately 10% to 20% of patients with FAB-M2 acute leukemia have a translocation of T8, 21, Q22, Q22. This translocation is usually seen in young patients such as JVC and is associated with a better response to therapy. JVC's bone marrow has been sent for cytogenetic and molecular analysis. However, results will not be available for approximately a week. Although neither the cytogenetic nor the molecular analysis will alter the planned induction therapy for JVC, these findings in combination with other prognostic features, as discussed previously, will influence post-remission therapy recommendations. My next question to you reads: what is the goal of treatment and what type of therapy is indicated for JVC at this time? The leukemic cells populating JVC's blood are abnormal and incapable of fighting infection. Their rapid proliferation is suppressing red blood cell and megakaryocyte production in the bone marrow. JVC is at substantial risk for life-threatening infections and bleeding complications. The goal of the initial chemotherapy is to clear the bone marrow and peripheral blood of all blast cells in the hope that normal blood cell components can regenerate. We will now briefly look at induction therapy. Standard induction chemotherapy for acute myeloid leukemia includes an anthracycline, either daunorubicin or idarubicin, and cytarabine, an antimetabolite. One commonly used regimen includes idarubicin 12 mg per meter squared per day on days 1 to 3 as an IV bolus injection, plus cytarabine 100 mg per meter squared per day as a continuous IV infusion on days 1 to 7. This combination, that is 7 plus 3, is one of the most effective chemotherapy regimens used to treat adult acute myeloid leukemia, with CR rates of 60% to 80%. Continuous infusions of cytarabine are preferred because these regimens produce higher response rates than bolus injections during induction therapy. If a patient presents with a very high WBC count, he or she may experience complications associated with hyperviscosity of the blood, e.g., ringing ears, stroke, blindness, or headache as a result of impaired oxygen delivery to the central nervous system, CNS, pulmonary infarction. Because it may take several days for cytarabine and idarubicin to substantially decrease the WBC count, the patient may receive hydroxyurea 2 to 4 grams orally or undergo leukapheresis to rapidly reduce the WBC count. Leukapheresis is not routinely done unless the patient is experiencing symptoms of hyperviscosity or has a WBC 100,000 cells per microliter or greater on diagnosis. Because JV's initial WBC was 180,000 cells per microliter, leukapheresis was initiated together with concomitant hydroxyurea 2 grams twice daily. Approximately 12 hours after initiating leukapheresis, JVC's WBC had decreased to 85,000 cells per microliter and he was stable enough to proceed to induction therapy with idarubicin and cytarabine. The leukapheresis and hydroxyurea were subsequently discontinued. My next question to you reads: would induction therapy for other subtypes of acute myeloid leukemia differ from that described previously? Induction therapy with 7+3 is standard for all types of acute myeloid leukemia, with one exception: acute promyelocytic leukemia, also called AMLM3. Acute promyelocytic leukemia is uniquely characterized by the T15, 17 translocation that fuses the PML gene on chromosome 15 to the retinoic acid receptor alpha, RA alpha, gene on chromosome 17. In clinical trials, tretinoin has induced complete remission in approximately 90% of patients with acute promyelocytic leukemia. Serial bone marrow aspirations after initiation of tretinoin therapy demonstrate progressive differentiation without hypoplasia. Unfortunately, tretinoin typically induces brief remissions. A number of trials have investigated combination treatment with chemotherapy and tretinoin. Current evidence supports the use of concurrent tretinoin with arsenic trioxide or an anthracycline with or without cytarabine for induction in the treatment of low-risk acute promyelocytic leukemia. For high-risk acute promyelocytic leukemia, conventional chemotherapy remains the standard of care. In addition, post-remission therapy should include at least 2 cycles of an anthracycline-based regimen. Maintenance therapy with intermittent tretinoin has been shown to decrease the relapse rate. Tretinoin therapy, although avoiding life-threatening myelosuppression, can produce significant toxicities, including the differentiation syndrome, formerly called retinoic acid syndrome, which manifests as fever, weight gain, respiratory distress, lung infiltrates, pleural or pericardial effusion, hypotension, and acute renal failure. If this syndrome develops, corticosteroid therapy, dexamethasone 10 mg twice a day for 3 to 5 days with a taper over 2 weeks, should be initiated. Tretinoin also causes dryness of the lining of the mouth, rectum, and skin, hair loss, skin rash, blepharoconjunctivitis, corneal erosions, muscle weakness, nail changes, depression, elevated liver enzymes, and high cholesterol. Despite the risk of serious complications and death during induction therapy, the long-term disease-free survival, abbreviated as DFS, rate of patients with acute promyelocytic leukemia is superior compared with other acute myeloid leukemia subtypes. Approximately 75% of patients who receive tretinoin-based induction and maintenance therapy are alive 3 to 5 years after diagnosis. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 464.